Okay, so we are back with you. Now, I was just telling you about the differential diagnosis, and in adenomyosis, of course, as I've already mentioned, it is a uniformly enlarged tender uterus with severe congestive dysmenorrhea. Now, coming to evaluation, as you've known, evaluation actually carries 4 marks here, isn't it? So, one has to be a little more uh, see, evaluation here carries 4 marks. So you look at the marks and decide on the number of points that you have to incorporate. So history, of course, is important, which is given here. Now, coming to physical examination, one has to go about a thorough general as well as gynecological evaluation, which is very important. Physical examination. Investigations, regarding investigations, one important thing I would like to stress upon here is any patient who is a potential candidate for surgery should have uh, specific investigations that will help you arrive at the diagnosis and decide on the management, as well as the routine investigations. Now, routine investigations are generally investigations which are pertaining to the preoperative workup of the patient. So, specific investigations here would be a transabdominal or a transvaginal ultrasound, because ultrasound is the most easily available non-invasive investigation that we all do in our patients. Now, one important point about ultrasound here is there is something called as fibroid mapping, because here we have decided to go about with a myomectomy, because that would be the most ideal management for this patient. So, as far as myomectomy is concerned, one of the key principles of myomectomy is that one has to enucleate all the fibroids, including even the tiniest of seedling fibroids, because if you don't enucleate all the fibroids, she is going to end up with a recurrence. So, a 3D ultrasound is a very important, is a very useful modality to map the fibroids. Though we say that MRI would be the best modality to go about a fibroid mapping. Now, the other specific test would be a pap smear, considering that she is only 36 years, and of course, an endometrial sampling. Though, even if the diagnosis for the heavy menstrual, even if the cause for the heavy menstrual bleeding is glaring at you, it is always important to sample the endometrium, because you can have associated pathological changes in the endometrium as well in a case of fibroid uterus. So, an endometrial sampling with a PIPEL is also equally important. So, divide your investigations into routine investigations and specific investigations. So, these are some of the points in which you have to answer. The next question was about counseling. Now, here counseling is important because she's a young woman, and we have decided to go about with a conservative surgical modality. Now, the most important thing here is to counsel her regarding the surgery that we are planning to undertake. And of course, most hysterectomy is not in our agenda at all, because she is still young and has not completed her family. But if it's a case of previous one cesarean section, she is likely to have adhesions, sometimes bladder adhesions or other kind of intraperitoneal adhesions, which may add to the risk of injury or bleeding. So, the need for blood transfusion in excess of intraoperative bleeding. There are efficient methods for controlling intraoperative bleeding by injecting dilute vasopressin. So, all that can be the various techniques by which we reduce intraoperative bleeding can also be explained to her. Then, of course, there are long-term complications, and which have to be discussed with the patient, which is the possibility of a recurrence. Because if you have missed out on a few seedling fibroids, these can recur and can again give rise to the same set of problems which she has gone through. So, she should not feel that the surgery was incomplete or was not properly done, because this is a well-known complication, a recurrence of fibroids. Then, of course, post-operative adhesions, and also these can have long-term repercussions on the obstetric outcome, like a rupture uterus. So that also has to be impressed upon the patient, because she is a high risk patient now once she undergoes a myomectomy and becomes pregnant at a later date. Next comes the management. Now, how much marks does the management carry? It carries 4 marks. And see the phrasing of the question: discuss the management in this case. So it carries 4 marks and you have to discuss. So one important point that I would like to stress when you are asked about such a case is that, see, fibroid is an entity. Why I particularly selected fibroid for you is because this is one particular entity which has umpteen number of management options. You have the medical option, you have the non-surgical conservative options, you have the surgical conservative options like the myomectomy, then you have the radical surgical when we go ahead with a hysterectomy where you don't want to salvage the uterus, etc., etc. So there is no point in elaborating the entire list of management options available. You have to discuss what is the most appropriate management for this particular patient for this given case scenario. So that is why I specifically selected this case scenario. So discuss the management in this case means you discuss only the management options that you are going to put forth for this particular patient, and discuss because it carries 4 marks. So you can analyze the various aspects in this particular case and bring forth your points. So, how do you go about that? See, management options. The most important thing is myomectomy. Now, there are two routes for myomectomy. You may go laparoscopically, or you can do a laparotomy. That depends on the surgeon's choice, the findings of the findings in that particular case. So, what exactly is the route of surgery that you prefer? Will um, um, you can go about the management according to the route of surgery that you prefer. Now, another important thing when you think about a myomectomy is we always go by tunneling incisions. See, because it's a case of multiple fibroids, we don't put multiple incisions all over the surface of the uterus. So we put an incision on the most prominent part of a large fibroid, and then through that you can make tunneling incisions, and through the same incision you can remove all the small fibroids or the seedling fibroids in the vicinity of the all the other fibroids in the vicinity. Then I told you about the role of vasopressin, which is a very good hemostatic agent which reduces intraoperative blood loss. Then one of the important principles is to remove all the seedling fibroids. Perfect hemostasis is very important. Good approximation of the endometrial cavity if you have entered the endometrial cavity during the enucleation is important. So all these things have to be mentioned in your management. And of course, there is a very remote or a very rare possibility of hysterectomy if you can't control the bleeding, but that seldom happens in the hands of a good surgeon. So you need that's a little too far fetched, but you have to mention all the other salient points in the management of this particular patient. Now the next question was, what are the non-surgical modalities? So, and it carries only 3 marks. So you have various non-surgical modalities. So starting from the medical management, where you have the various drugs available, but two important categories of drugs that are available as far as the medical management is concerned is the selective progesterone receptor modulator, the GnRH channeler. So you can briefly give the salient, just in one or two sentences, you can mention what they are and what their role exactly is. As I told you, this is not a theory class, so I will not go into the details of all these management options. Then you have the uterine artery embolization, you have the high intensity focused ultrasound, myolysis. So a sentence or the two about each of these various management options is all that is called for. You need not, because each one is a topic for a short note or a short essay. So you need not go in a short note, in fact. So you need not elaborate on each of these at length, but just give a brief account, very brief account in a few sentences about each of these, because it carries only 3 marks. So that way you have to learn to put your answers in a very concise manner, depending on the marks that are allotted to each question. So I suppose this is one way of answering an essay of 15 marks, where you have been given, where the questions are divided according to the marks allotted. So the total of 15 marks has been divided into questions carrying 4 marks each, two questions of 4 marks each, so that has to be dealt with at length. Then another question carrying 2 marks, and another question carrying 3 marks. Now, similarly, to give you an example of an obstetric problem, I just thought I will take two sample scenarios from each of these cases. So, the obstetric cases, Mrs. X, 28 years old. So, the principles are the same as you have seen in the gynae case. 28-year-old, second gravida, para 1, living 1. The first one was a full-term normal delivery. Her last childbirth was 3 years. And it's already given that it's a case of twin pregnancy, referred at 38 weeks with labor pains. So she's a high risk patient with a twin pregnancy, and she carries 15 marks. So, as I mentioned, please note the catch words here. This is discuss or mention. So, when you are given discuss, they expect a little more of discussion points here, because it carries 5 marks. So discuss the intrapartum management, because a woman has already come in labor. You need not start with the antenatal history and all that. You start off from where it has been given. So intrapartum management. So when the woman comes in labor, what are all the things you start doing for this particular patient? Then comes, now, because there are two fetuses here, the second of twin is always at risk for so many known reasons, and there are so many management options for the second of twin, depending on the lie and the presentation and things like that. So the first of twin, even if it is born easily as a vertex presentation, there can be problems for the second of twin. So again, it is said, discuss the management for the second of twin. Then how will you manage the third stage? Of course, it is understood the third stage is not very different from the other cases, but for the twin pregnancy, there is this added element of atonic postpartum hemorrhage, which one should be aware of and should be ready to tackle with adequate precautionary measures. And the last question is mention. So you need only mention, and it carries only 2 marks. So don't go on elaborating on each of the points that are known to you. See, simply answering, simply adding to the explanation and description where it is not really called for, is not going to fetch you marks. We really don't decide on the marks depending on the number of pages and pages of answers answering that you have done. But as long as it carries all the points that are expected of you, and you have answered to the point depending on the marks the question carries, we will be giving you near complete marks. So unnecessarily beating about the bush is to be avoided if you need to strictly have a proper time management. So time management is very, very important, and that is the technique I was telling you. Look at the marks, see the catch words in these questions, and decide on your answers accordingly. So how do you go about it here? See, discuss the intrapartum management. So examination is very important. She might be a hypertensive. Look for blood pressure, pallor. Look at the uterine contractions. Do an NST, because all these things are part of preparation, the preparatory part for the woman in labor. Ensure that blood and blood products are ready. What exactly should the woman be given? Whether you can give her clear, whether she can be given oral fluids, or whether you should give her only parenteral fluids and restrict oral fluids. So NPO is not strictly mandatory. She can have clear fluids, but do not stuff her with solids, because it will very much delay the gastric emptying time and make her high risk for the second of twin in case it ends up with a cesarean section. So then, of course, there should be a delivery team. There should be 2 delivery sets, the 2 neonatologists available. The other ancillary things are continuous electronic fetal monitoring. See, I'm just giving you the points that you should mention here. A partogram is very important. Sedation is important. Antibiotics after the artificial rupture of membranes when she is in active labor is important. Oxytocin augmentation if required. It is not mandatory and need not be given as a routine for all. And a vaginal examination is done only fourth hourly, generally speaking, isn't it? So these are some of the these are some of the things that have to be available in a delivery suite, in for any, especially in a high risk patient like a multiple pregnancy. Next comes, so that way you carry the woman to full dilatation. She delivers the first of twin. Now the next question is, how will you manage the second of twin? The intrapartum management of the second of twin. So there you have to say, if depending on whether the second of twin is presenting as vertex or breech. If it is a vertex, there is nothing very different from what you need to do. You can do very well do an artificial rupture of membranes and wait for spontaneous delivery. So also, see, all that matters in a second of twin is that it should be a longitudinal lie. It is not important whether it is a vertex or the breech, because as long as it is a longitudinal lie, you can expect a vaginal delivery without much of a problem, because the babies are also expected to be relatively small. So there is not going to be an element of cephalopelvic disproportion or fetopelvic disproportion generally, because they're small babies. So deliver accordingly. Intrapartum USG can be made use of soon after the birth of the first of twin. If the delivery suite has an ultrasound machine, you can very well use the ultrasound to note the lie and presentation of the second of twin, rather than blindly going and doing an artificial rupture of membrane and encountering a cord prolapse or something like that. So intrapartum USG is very, very important and very useful for the management of the second of twin. Now, the problem arises if the lie is a transverse lie, in which case our first option would be an external version, which could be an external cephalic version where you try to bring down the head, or an external podalic version where you try to bring down the breech. So generally speaking, we call it as an external version. Now, if the external version is not successful, then you have to immediately shift the patient to the theatre, where you will contemplate an internal podalic version and a breech extraction. So the internal podalic version is always followed by a breech extraction. Now, this is usually done in a double setup. That is, you keep everything ready for cesarean section. If the IPV fails, you immediately proceed with the cesarean section. So that is how the management protocol goes. So for the second of twin. Now, so this all these points should be elaborated a little more in detail, because it carries 5 marks. The next question is, how do you manage the third stage? Now, active management of third stage of labor is recommended in all women after every delivery in every institution. So that is actually a prevention for PPH. It is not the management of PPH. It is actually to prevent postpartum hemorrhage, and it is a universal procedure to be undertaken. All the more in a multiple pregnancy, where one of the most important complications of third stage is a postpartum hemorrhage. So, examination of placenta and membranes soon after delivery is important, and ensure that the uterus has become well contracted and retracted at the end of the third stage. And also, one should continue oxytocin for about 4 to 6 hours, and watch for PPH in the delivery suite. And of course, we have already discussed the importance of arranging blood and blood products for these high risk patients earlier on. So, briefly, you can discuss the problems that you are anticipating and what exactly you will do. Then the next question was, mention the complications unique to monochorionic twins. So this is mention, and it carries only 2 marks. So you need not elaborate too much on all these problems. So these are though there are so many other complications in pertaining to twins, there are a few complications which are inherent to monochorionic twins, purely by virtue of sharing of the blood vessels between the twins. So the twin to twin transfusion syndrome, the twin oligopoly sequence, the twin anemia polycythemia sequence, the twin reversed arterial perfusion, the monochorionic monoamniotic twin, the conjoined twins. These are some of the well-known problems of monochorionic twins, and which make matters more complicated for a monochorionic twin. Now, because it is said mention, if you can mention the entire list of problems that we encounter, that is good enough. You may even expand these short forms, and if time permits, a word about what exactly it is, because each one, again I tell you, is a question by its own, so you need not elaborate too much on these problems, but make sure that you mention the entire list of complications with full forms. So I think that was my last slide. Now, I have just given you a brief overview as to some of the important points to be paid attention to. Now, the other segment which I wanted to stress upon was many a time I find two, three things which have always come to my notice is when students answering unnecessary things that are not expected of them in that particular question. So they just want to add matter to the answer. That is not really going to help you other than waste your time and encroach onto your time. So be precise, be specific, and stick to the question that is given to you. So if it is management with regard to this particular case, it is only with regard to that particular case. Do not deviate from the question. And regarding the one word answers, which is again an important area where you can score marks, because by just answering one word, you have a total of 8 marks that you can score there. Here again, I find people writing something like a short note, which is not actually required, which is not called for. So if it's a one word answer which carries only 1 mark, please limit your answer to one word or expand or whatever be the question. So read the question properly and limit your answer to that. And of course, some of the common diagrams that are asked in the exam should be well prepared. Bring color pencils or colored pens to draw diagrams neatly and label them properly. So I think with these small tips, I think most of you can score good marks for the theory paper. And having an overall idea and managing your time is very, very important. So read the question properly, see the marks that it carries, and then start answering. So even before you read the question properly, don't start with your answers. So and in the first slide I had given you a list of points that that if you take care of, will really go a long way in fetching you good marks. So wishing you all the best. Thank you so much. I hope this will be of some benefit to all of you.